This seminar is focused on the east direction of compass, which is to engage the client's body and mind for optimal stroke recovery. At the end of the seminar, you will be able to recognize that survivors of stroke are at increased risk for physical inactivity due to their deficits. They are at risk for falls and rehospitalization. And understand the importance of overall physical activity, the importance of structured and progressive exercise programs, falls prevention, and how to promote self-management, all utilizing the patient's individualized plan of care. In this seminar, we will cover an overview of the Compass Movement Matters activity program, the Movement Matters directional components for fitness and health, upper extremity dexterity and function, safe and independent mobility, functional assessment tools that you can use to evaluate your client's function, and then use those results to tailor your structured and progressive exercise program and physical activity recommendations, physical activity counseling principles, and finally, we will end with a case study to illustrate the Movement Matters implementation. Let's put into perspective the experience of survivors of stroke. Survivors are at risk for being physically inactive. Over half of survivors do not achieve activity levels recommended for health and well-being. The American Heart Association recommends everyone get at least 150 minutes of moderate intensity activity per week. That boils down to roughly 30 minutes a day, 5 days a week. However, we know that survivors, on average, spend approximately 3/4 of their day lying or sitting down. We also know that inactivity increases the risk for suboptimal brain repair after a stroke, and that inactivity increases the patient's risk of having another stroke. Survivors are also at risk for falling and fracturing a hip. They fall 2 times as often and are 4 times as likely to fracture a hip compared to the general population. Falls are more likely to happen in the patient's home and are most likely to occur soon after transitioning home from the hospital or a rehabilitation facility. Survivors are also at risk for losing arm function. More than 2/3 of survivors experience upper limb paresis. As a result of this, they have difficulty with basic everyday activities of daily living, including dressing, bathing, cooking meals, and writing, to name a few. Survivors are also at risk for rehospitalization when they are discharged home with little or no rehabilitation. Currently, only 32.5% of Medicare patients who are discharged home receive physical or occupational therapy services within 30 days of discharge. Are you all surprised by those numbers, or does that sound like a familiar scenario? Home health and outpatient rehabilitation services for this population are essential for recovery of function, independence, and overall health and quality of life, but many people who need these services are not receiving them. Our partnership aims to change this statistic. Information on this slide is based on yet-to-be-published work from our Compass team member, Janet Freeberger, associated with UNC's Shep Center. These numbers are pretty compelling, and not in a positive way. Of Medicare patients discharged home after a stroke, 25% received home health therapy in the first 30 days post-discharge, and an additional 9% received outpatient therapy services in that same time frame. That means that 66-67% of patients discharged post-stroke did not receive any therapy services in that time frame. Of a home health therapy subgroup, 99.7% of those people saw a physical therapist, but only 44% had occupational therapy treatment. And of the outpatient therapy group, 90% of those people saw a physical therapist, but only 35% saw an occupational therapist. Importantly, the intensity and number of visits in the first 30 days post-discharge is associated with a decreased risk of hospitalization in the subsequent 30-day period. Again, this is where our partnership aims to impact both the quality of life of the survivor and the healthcare system overall. Summing up the evidence, we know that movement matters for functional recovery regarding fitness and health, upper extremity dexterity and function, safe mobility, and independence in the home and community. Thus, our motto, movement matters. We, as a team, have taken a deep dive through the resources and have constructed recommendations for activity based on these resources. We are now providing you with a concise packet of recommendation based upon the evidence. Some of these recommendations and programs are items you may already be aware of and utilizing in practice. Just as a summary, the American Heart Association and American Stroke Association put out a scientific statement in 2014 for physical activity and exercise recommendations for survivors of stroke. The conclusion read, "The recommendation from this writing group is that physical activity and exercise prescription should be incorporated into the management of stroke survivors. The promotion of physical activity in stroke survivors should emphasize low to moderate intensity aerobic activity, muscle strengthening activity, reduction of sedentary behavior, and risk management for secondary prevention of stroke. To reduce the aforementioned risks and promote the recovery of fitness and health, upward extremity dexterity and function, and safe mobility and independence at home and in the community, the engagement component of COMPASS, the Movement Matters Activity Program, prescribes an evidence-based, structured, and progressive exercise and physical activity program. The MAP also includes concise algorithmic summaries to assist the healthcare provider in matching the most suitable health service setting, for example, home health, outpatient, community-based, with the survivor's functional capabilities and insurance benefit coverage. Lastly, the MAP details its alignment with government-mandated healthcare quality reporting measures. Before we get into the nuts and bolts of the MAP directions, let's review key definitions of terminology we will use in this seminar. Physical activity is defined as bodily movement produced by contraction of skeletal muscles that results in a substantial increase in caloric requirements over resting energy expenditures. Exercise is a type of physical activity consisting of planned, structured, and repetitive body movements done to improve and or maintain one or more components of physical fitness. Physical fitness is a set of attributes or characteristics individuals have or achieve that relates to their ability to perform physical activity. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. The MAP prescribes 3 essential components. The first of those is exercise. Exercise must be structured and progressive and provided across a variety of domains including muscle strengthening, balance and coordination, flexibility and endurance. We have to continue to challenge the patient throughout their recovery, or we cannot expect them to continue to maximize their recovery. The second essential component is physical activity outside the structured exercise sessions. There is increasing evidence that one bolus of exercise in the day may not be enough to maintain health, and that the moments of activity outside the block of exercise may be just as important in terms of health and longevity. For many of our lower level patients who can't do a lot at once, that means continuing to message that all time and activity adds up and that we must keep moving. Lastly, we have to empower our clients to care for themselves and to self-manage, be it their meds, their vitals, their exercise and activity regimen. The goal is to help maximize our clients' independence and quality of life. You are key players in teaching clients the how-tos of self-management. In this section, we will discuss the specific activities of the MAP for fitness and health, upper extremity dexterity and function, and safe mobility and independence. Prior to describing the specific activities, let's first discuss the practical implementation principles that serve to guide the MAP. Our first guiding principle is build the base. If you look at the graph below, functional level is on the x-axis. Your most frail patients will be likely toward the left side or level 1, and patients with less significant deficits and or comorbidities being toward the right or closer to level 4. The y-axis indicates the percentage of the types of therapeutic activities your client should be engaged in, including cardiovascular, strengthening, balance and coordination, and mobility. Thus, with a client who has lower functional abilities, therapist intervention will spend proportionally more effort on basic mobility, balance, strengthening, with less focus on cardiovascular endurance. For the patient with very little balance and mobility deficits, the bulk of the therapeutic regimen will focus on strengthening and cardiovascular fitness. That well may be provided by a community exercise program instead of formalized therapy. We have to deliver therapeutic interventions that are tailored to our clients' needs and ability to participate while keeping in mind how to progress them to the next level. Our second guiding principle is start low, progress consistently. The recommended amount of physical activity for all adults is 150 minutes per week. However, survivors of stroke may not be able to perform the recommended amount soon after hospital discharge. Therefore, progress the amount of activity your client is engaged in consistently over time. As shown below, minutes of physical activity is increased consistently over multiple weeks. Also, shorter time intervals performed multiple times per day count toward total activity minutes. As shown below, minutes in different activities are added together so that the total time is progressively increased over each session. Our third guiding principle is early, consistent, and sustained intervention is critical. Activities must be practiced frequently and consistently for neural pathways to repair appropriately. We know that the greatest ability to repair occurs in the first 12 months after stroke, and additional studies indicate that the first 3 months may be the most critical time for repairing brain circuits, especially for upper extremity function. Our fourth guiding principle is to reduce fall risk. Balance and strength exercises are essential components of intervention regimens to reduce falls in the elderly, as well as those with stroke. Be sure to avoid brisk walking in high fall risk individuals. Be attuned to medication side effects and postural hypotension. Use a gait belt for dynamic standing activities with fall risk individuals. Recommend safe footwear. A home safety assessment is essential for reducing fall risk and exercise safety. Please visit the following CDC website for a free assessment tool, as shown in the web link here. Our fifth guiding principle is foster self-management. Tips are to facilitate understanding of general physical and mental health benefits of regular physical activity and exercise. Integrate activity and exercise in the context of the individual's lifestyle preferences, personal goals, and functional tasks. Be sure to modify the exercise and activity prescription to consider stroke-related asymmetries in the upper extremity and lower extremities to maintain pain-free and enjoyable activity performance. Strike a balance between promoting autonomy and providing support by encouraging caregiver and or family involvement, identifying weekly task goals and monitor completion of task goals. Consider the use of a behavioral contract. Lastly, our sixth guiding principle is to own the care transition. Use of services to facilitate stroke recovery will vary based on the survivor and caregiver's, if one, needs, coverage benefits, and preferences. Some survivors may progress through all settings. You can see here from home health therapy on the left-hand side, in the middle to outpatient therapy, and finally to community-based programs, while others may skip settings or start somewhere along the continuum. Some survivors will be candidates for the community-based programs or self-management following hospital discharge, while others may benefit from formal therapy in the home and or outpatient setting. Your clients should be provided with the most suitable services to maximize their potential for recovery and achieve the ultimate goal of self-management of physical activity and exercise. At each level, the treatment team must take responsibility to help shepherd the client and caregiver to the next appropriate setting of care. Let's now look at the specific components. Our first components are warm-up activities and flexibility. You can see here the suggestions for warm-up activities. These are noted on the slide. For instance, flexibility exercises should be incorporated 2 to 3 days a week, either before or after aerobic or strength activities. Muscle strength. These activities should include all major muscle groups. You can use circuit training and or functional mobility exercises such as sit-to-stand step-ups. Evidence shows these should be performed 2 to 3 days per week at 1 to 3 sets with 10 to 15 reps each. Intensity can be monitored using the rate of perceived exertion scale. There are 2 scales you may be familiar with. There's a 0 to 10 scale and a 6 to 20 scale. Here are the 2 RPE scales side by side. RPE ranges for strengthening are a 13 to 16 if you are using the 6 to 20 scale, or a 4 to a 6 if you use the 0 to 10 scale. Let's now review strengthening principles in one slide. Intensity should be moderate, 10 to 15 reps before fatigue. Progression should include an increase from 1 to 2 sets. If using weights, increase after the client or patient can do 2 sets of 10 to 15 reps. The duration should be 30 minutes. This can be divided up throughout the day. Frequency, 3 times per week, is evidence-based with rest days between sessions. And longevity, the goal really is to have your client become safe with these and adapt an ongoing independent exercise regimen. Let's look at functional strengthening examples. We use the evidence-based Otago Falls Prevention Program as a model for the recommended exercises in the map. Weights or reduced support can be used to increase the challenge, as shown in the pictures on the slide. Please visit the Otago site on the UNC website shown on the slide, where it will have the selection of exercises that we show in the seminar. Again, here are more strengthening exercises. We can add weights or reduce support to increase the challenge. Stair walking and sit to stand can be strengthening exercises. Challenge can be modified by using different techniques or support, either step 2 through or step 2, or without support of the rails, or using arms and positioning buttocks differently in the chair. For instance, standing from a buttocks in the back of the chair with no arm support is more challenging compared to buttocks at the edge of the chair and use of both upper extremities to stand. In order to increase balance and coordination, these activities must be practiced. Sample exercises include reaching forward or backward and outside the base of support, start and stop walking, accelerated or decelerated gait, and braided gait. Ideally, these should be practiced 2 to 3 days per week. Remember, these are dynamic activities, and if performing over a continuous bout, these will count towards the total activity minutes for the day. For instance, 5 minutes of mobility exercise count toward total minutes of activity. You want to consider starting with support and progressing to lesser or no support as your client progresses. Similar to previously mentioned exercises, unsupported versus no support changes the challenge of these activities. Again, here are more examples of walking with or without support and different types of coordination activities. Again, examples of activities that you can incorporate into your treatment plan. Knee bends with support and without support can challenge both strength and balance. Cardiovascular. Examples of these activities include rhythmic activities that engage large muscle groups such as walking, stationary cycling, or arm ergometry. 5 days per week has shown to have the greatest health benefit. Progress minutes per day consistently over time and work toward that 30-minute per day goal that all Americans should have. Clients should work at a moderate intensity, which is an RPE of 2 to 4 on the 0 to 10 scale, or 11 to 14 on the 6 to 20 scale. Remember, multiple bouts per day of shorter time intervals count towards total minutes. And shorter intervals should include at least 10 minutes of continuous or sustained activity, as only 10 minutes has been shown to have health benefits. Consider the use of a pedometer or other activity monitor to promote increased lifestyle physical activity. Benefits to cardiovascular fitness training include reduced blood pressure, lower incidence of cardiovascular events, lower fat mass, improved mobility, improved glucose control, and improved energy levels and greater resistance to illness and fatigue. Time spent in continuous activity must be progressed to achieve benefits. There is a dose-response relationship whereby exceeding the minimum recommended amounts could lead to further improvements in fitness. These activities can be performed at home or in the immediate built environment, in an outpatient facility, or as independence and self-management improves, in community-based programs, again, depending upon your client's functional status. Please see these informational resources on our website for recommendations from the American Heart Association and the CDC. Remember, survivors are at an increased fall risk, so be sure to assess the home environment and recommend the safest place to walk. Incorporate independent walking only when physically ready and able. Consider using assessments, such as a timed up and go. Greater than 12 seconds for that task is considered a fall risk. Track gait speed over time. Less than 0.6 meters per second should be limited to the household. Less than 0.8 meters per second gives concern for community mobility safety. Again, consider beginning walking indoors and advance to outdoors when strength and balance are sufficiently improved. Additional walking tips for you as the provider or your client are available on the Otago site under the implementation guide, and then go to tools for practice. We will now discuss the specific activities of the map for upper extremity dexterity and function. The brain has the most ability to repair and improve hand function in the first 3 months after a stroke. During this period, the brain has enhanced plasticity and is more sensitive to stimuli and experience, such as fine motor exercise. Hundreds of exercises are required to regain upper extremity function. GRASP, or Graded Repetitive Arm Supplementary Program, was developed by Compass team member Janice Ng, and it is a home-based, structured, and progressive, self-directed upper extremity exercise program to improve arm and hand function after stroke. It has been tested in a randomized controlled trial, and the results have been published and shown to be effective. To access the program for free, please visit this website and then click on the GRASP icon. Please note, clients who do not have active shoulder shrug and wrist extension movements and or have significant muscle stiffness of the hand and or arm should be referred to occupational therapists or to physical therapists if occupational therapy is not readily available for stretching, ADL management, and exercise instruction and progression. GRASP has 3 exercise levels to accommodate different levels of stroke severity. Shown in the slide are some examples of exercise ranging from range of motion to dual bilateral tasks. Some tips on using GRASP: progress the patient weekly to undertake challenging repetitions. For instance, use equipment with a range of sizes to increase the challenge. For example, poker chips to dimes, popsicle sticks to toothpicks. Exercises need to be difficult. Your clients should mishandle or drop an item at least every 10 repetitions. Otherwise, you need to make it more challenging. Emphasize to the client, the more you use your hands, the more your brain relearns how to control the muscles. Another tip: set targets and activities to use the stroke-affected hand during ADLs. Consider setting and checking targets on daily hand use. You may ask your client weekly, how often did you use your stroke-affected hand yesterday? For example, 10% of the time during activities of daily living that require hand use or more. Brainstorm ways with your client to increase daily hand use. Challenge your client to think of some difficult but safe ways that they can use their stroke-affected hand in that week to increase the amount they use their hand. Examples could include using the stroke-affected hand today to open the door, brush your hair, or eat your lunch. Make the patient and family accountable. Record the agreed-upon activities and ask the client or patient if he or she used their hand as planned. In this section, we will discuss the specific activities of the MAP for safe mobility and independence. Otago and Life are fall prevention programs that have been tested in controlled trials, and the results have been published and shown to be effective. The Otago exercise program, which we have introduced previously in the functional mobility tasks, consists of a series of 17 strength and balance exercises prescribed and delivered initially by a physical therapist that reduces falls in the frail older adults living at home. The program description and implementation guide can be found on the website shown on the slide. Another falls prevention program is LIFE, Lifestyle Integrated Functional Exercise Program, developed by Lindy Clemson, Maria Singh, and Joe Monroe. This program aimed at reducing falls and improving function by embedding balance and strength activities into daily routines and tasks. It uses traditional dual task training to improve overall function and balance. For example, brushing teeth becomes an opportunity to improve balance. Unloading the dishwasher becomes an opportunity to improve strength with squats. Life should be restricted to clients who are high functioning and primarily neurologically intact. There are 2 life manuals, one for the participant and one for the trainer. The participant manual is free at the website below, and the trainer manual is available on the web. We highly suggest that your facility purchase the trainer manual for provider shared use.